Welcome back to the first lecture of Part 6, Adopting AI Solutions in Medicine. Throughout the course, we've talked about the development of artificial intelligent machine learning solutions for medicine. So ultimately, our goal should be to help the patient. Now, the first step to get there is implementing our solution, so whether it be CAD or an AI/ML solution, into clinical practice. So how do we do that? Let's first define what we're talking about. So we have developed a CAD system or an artificial intelligent machine learning solution that is a type of software or system that is going to help the healthcare team treat patients or diagnose patients. Ultimately, that's what it is. This is called a clinical decision support system or clinical decision support software. Now, the algorithm we develop, for instance, can be embedded into a CDSS, or it can be a full CDSS on its own. Now, bottom line, a CDSS will provide clinicians or the care team with knowledge at the appropriate time, presented in the appropriate way in order to enhance the care of patients. But bear in mind, it is also a system, so it's an effective pathway for providing all of this, all of these great tools. And it is also, it can provide as well, quality assurance. It can provide efficiencies. It can provide monitoring, alerting, all of the above. Now, what we are interested in doing is having the CDSS incorporate our algorithm, our wonderful AI machine learning solution, and then being used in the healthcare setting. And that is what we're talking about in this lecture, is what are the facilitators and barriers for using this new CDSS? Let's go over a few characteristics of CDSS. So we have temporally ordered steps, each leading to new data, which in turn becomes useful for a new decision. This is like a pathway. Feedback loops where acquisition of new data improves certainty and generates new questions to examine. A little bit of decision tree there. Combining different kinds of clinical data for decision making. That is, a hot topic these days, because we now have the ability to process large amounts of data and diverse data on the fly in order to inform a system. There's also the reusing of the same data in two or more different decisions. This is always useful, that once you've entered data, it can then be used at different points in time. It can also be used in different contexts. And finally, what is very useful is you now have a blending of decision making that can be made by both human cognitive skills and machine cognitive skills. And this is becoming more and more the topic of discussion, where can it only be machines? In the future, could it seriously just be machines that make the decisions, or not? I believe not for a while, and we're going to have this mix of the two, and it's great actually, because it makes it easier for those involved in the process, and it also provides some safeguards, right? So if you're a little tired or you need a second opinion, so it improves the process. Okay, let's have a quick refresher, because we discussed this in the third lecture. What is CADe? So that's computer aided detection. And the goal here is to reduce false negatives. And what is CADx? CADx, that is computer-aided diagnosis, and the goal here is to analyze the likelihood that a feature in an image represents a specific disease process. So where are we with all of this CAD and AI ML solutions? Well, there's a lot of evidence to show that both CAD and AI have observable benefits in diagnostic specificity and selectivity, for sure. However, CAD and AI have not been implemented widely in the radiology workspace to date. So why is that? So this whole talk of artificial intelligence is new. Is artificial intelligence a new concept? No, it's been around, as we discussed, 1956. So CAD is not new either. It's been around many, many years. And interestingly, in 2007, a long time ago now, it was reached, by a paper by Doi et al. Reached the conclusion that, CAD was beginning to be applied and used in the clinical practice more frequently, as a diagnostic tool, and especially in the examination of abnormalities in medical images. Fine. Fantastic. That's 2007. Recent studies have also stated that CAD technology has shown major improvements and that diagnostic accuracy rates would benefit from the implementation of CAD. So it's funny that it still hasn't really taken off. So there are three fundamental ideas that need to be addressed in order for CAD and AI to be successful, I think, in the clinical space. The first one is basing the computer algorithms on the strategies and processes that would be involved in image readings by radiologists. I think that's a sweet spot, and it's kind of obvious, right? The next is protecting the IP related to the CAD or AI via patents to facilitate commercialization of the CAD products. So this is, of course, in order to encourage industry to create useful products. If, sadly, if you don't have the driver in order to build these solutions, then they just don't get built, or they're built very slowly, or the ones that are built are not that great, And lastly, promoting CAD widely through the field of radiology is an important point. And it's funny, that came out, in 2007. Because if you don't promote it, it's not going to be taken up. That's kind of an obvious one. So these are the three fundamental ideas that we need to address in order to be successful in putting out CAD and AI. Here's a more detailed look at some of the challenges that we face in order to implement these types of solutions in the clinic. So we start in the hospital and the clinic. This is where data collection and quality assessment occurs. So that in itself is a challenge, as we know, we've talked about it. Then you have your CAD system with the algo, basically. And so, the four challenges is, segmentation, advanced segmentation, feature extraction, all as we've talked about, good classification, data mining approaches. And then the last challenge is that, wow, how do we deal with big data? And we've talked about that as well, is that we're getting such an influx of data and different data that how do we deal with it is also a challenge. Now, as we've just mentioned earlier as well, is regulation and policy. So it needs to be safe, right? It needs to be a software that's been validated and abides to regulatory compliance. And so we have the developing of standardized performance assessment for the CAD systems. That's a barrier as well. And then finally, the adoption of the CAD system in clinical practice. And this is the piece that I'm trying to talk about or explain to you in today's lecture. Okay, so what needs to be done for a successful implementation? Well, a couple of things: necessary knowledge of the role that CAD and AI will play in the clinic needs to become standard within the workplace. And then the assurance that CAD and AI will serve as a tool So augmented intelligence as opposed to artificial intelligence, rather than a complete replacement of radiologists. Now, it's funny, I truly believe that radiologists will not be replaced by AI. I just think that slowly their job is going to change. Radiologists will improve what they're doing, make it keep it interesting, but it will change inevitably because they have this amazing tool now called AI in order to help them do their job. So yes, there'll be change, but it's not replacement. I really do not believe that that's going to occur. So let's look at some primary barriers to implementation. So as opposed to just challenges we've talked about, these are barriers. So radiologists do not trust CAD technology or AI technology. For sure, that is a barrier. Possible facilitators to the implementation of CAD and AI are the age and training of radiologists at present, which allows for trained professionals to acclimatize to the adjustment more easily. So what this means is a current barrier is that the radiologists that are in power today are not motivated to accept and promote this new technology. So we just literally need to wait for the younger generation of radiologists who are currently doing their residency or fellowship and are working with AI and CAD today during their training, so that as they accept positions as radiologists and then assume the senior roles as radiologists, then they will adopt or be more willing to adopt this kind of technology. Now, although CAD is a subset of machine learning and artificial intelligence, a better understanding of all these concepts throughout the clinical workplace is crucial. And that means everybody in the clinic needs to appreciate what AI does. And so, kudos to you guys taking this course, because you are learning about this process, technology, new developments, and this is how you are going to be more comfortable with it, and you're going to spread the word, right? You're going to say, well, actually, I'm not that scared of AI anymore because I know how it works. I know I can inform the process and make a product that I think I'd be happy to work with. Okay, a couple of other quick barriers. Inconsistent technical performance, that's always a bummer. Absence of guidelines, best practices, that happens too often, where you get this wonderful new tool that comes in and then, whoa, you have no idea what the guidelines are, what the best practices are in order to use it effectively. Limited communication between departments, so you have the perpetual struggle between departments, and the has departments and the has nots departments. Inconsistent acceptance trust of radiologists, that is right now is a big problem, because some radiologists are all over it and they think it's wonderful, and then you have a bunch of radiologists that still just say nope, 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 not going there. Now, acceptance trust of referring clinicians. Once again, you have to remember that we're a team, and so that's always a bit of a challenge as well. Reframe the professional identity, responsibilities of current roles is going to be needed in order to basically implement all of this technology successfully. The regulatory and legal uncertainties, of course, we've talked about that. Those are always big challenges. To have artificial intelligence assume responsibility for anything is a big deal. And then legal responsibility for mistakes, that's tied in, of course, in the sense that who's going to take responsibility if your software makes mistakes. Currently, everything is signed off by a human, and so the buck stops there in terms of whoever signed off on it. If it is going to be software that's going to sign off on it, who's responsible? Is it going to be the software company? Is it going to be the institution that purchased the software? Is it going to be the operator of the software? Et cetera, et cetera. So how are we going to assess the acceptance or the uptake of technology? So we have the Unified Theory of Acceptance and Use of Technology, UTAUT. maybe we'll call it UTAUT. And this is the model that evaluates how and why individuals adopt new information technology, and is the product of the amalgamation of several models and theories of individual acceptance, such as, and these are the four main ones, the theory of reasoned action, the technology acceptance models, the motivation model, and the theory of planned behavior. Now, there are four central constructs that you should be aware of, and they are the performance expectancy, which is the degree to which an individual believes that using the system will help him or her attain gains in job performance. The effort expectancy, which is the degree of ease associated with the use of the system. The social influence, which is the degree to which an individual perceives that important others believe he or she should use the new system. And facilitating conditions, degree to which an individual believes that an organizational and technical infrastructure exists to support. So how do we apply this UTAUT? I'm going to talk a little stats here, and it's not surprising that there has been an increased use of information technology systems across the healthcare sector, and a shift in the usage of the technology acceptance models to the UTAUT. And the reason for that is because the UTAUT can explain, or has been shown to be able to explain, up to 70% of the usage intention variance. So meaning, in statistics, if you want to explain, so your R-square, for instance, of linear regression represents the percent variance that is explained by your model. And so what it's saying here is that the UTAUT model can explain up to about 70% of the usage intention variance. And by using these models, we can better learn from, and understand how to correctly apply CAD and AI in the radiology space. So interestingly, if you've chosen your technology acceptance model, that's part of your UTAUT, you now want to use it, collect the data and make use of it in order to assess technology acceptance. So what exists are computer-aided auditing techniques and tools called CADs that, along with the auditors, do exactly that, collect the data to inform the model. Now, interestingly, a comparison is with the computer-aided diagnosis or computer-aided detection and radiologists. And there is a striking resemblance in that CADs and their auditors, the combination of the two, provide a fantastic system in order to study the uptake of technology or assess the uptake of technology. And it works a lot better compared to just the auditors, right? Just the human auditors that are going to, take as many measurements as they can in order to use their model. But they found that the combination of CADs with auditors is much more efficient. And it's funny, that comparison, that if you were to say, well, just radiologists, just like the auditors, it may be, and it would appear, that radiologists with CAD or AI will be better, will be a better solution. Anyway, it's just a comparison, but interesting. So what's the gap in the literature? The existing literature cannot predict what is required for CAD and AI to be adopted successfully by radiologists and, further beyond that, the healthcare team. So there needs to be future studies conducted to investigate these barriers and facilitators to CAD and AI implementation. And that brings us to the end of the first lecture of part 6. Next up will be the future of AI in medicine. See you there.